Yeah. So this will be an interactive session. That is why we tried pulling you people into the Zoom as well, though there is a live session also going on. So let's have a discussion rather than just a kind of a presentation now. Hardly 30 minutes for us. I'll just try to finish off at least 10 to 15 questions for now. And then the rest will be taken as part 2, part 3, and so on. Guys, are you here? We'll go on. Can the participants unmute and they also talk?
Yes, sir.
Yeah, perfect.
Yes, sir.
Yes. So you are going to give us the answer and how we are actually going to approach the question and stuff. So this is renal cell carcinoma, sunitinib, HFS, fatigue, mild hypertension. What is the problem with the question? Did this question have a CTCA grading?
No, sir.
No. So with this one word of mild hypertension, we'll try and assume that probably it's grade 1 bar grade 2. That is our assumption because they have very clearly told mild hypertension. And so probably they are meaning grade 1, grade 2 toxicity, which includes all these. Right. So among this, do we reduce dose or we treat them, or should we allow them to heal by itself or change TKI? First point, is there a point of changing TKI? Unmute, answer. There is no, this is not a class here.
No.
Yes, you are right. So no point of changing to another TKI. All these TKIs kind of act through what are all the receptors? What are these TKIs called as?
Multi-kinase TKI.
Yeah, so multi-kinase inhibitors. So there are so many receptors which is inhibited by these TKIs, like your VEGF, RET, EGFR, c-KIT. There's so many things. Each have different specificities for each of these receptors. And why do they cause hand-foot syndrome? Why do they cause hand-foot syndrome?
सर चुक्कू मैं एक बार वापस कर रहा हूँ एक मिनट में कॉल कर रहा हूँ वॉशरूम जाके आता हूँ
Some noise, guys. Why do they cause hand-foot syndrome? See, basically, one of the receptors is VEGF receptor, and one other receptor is EGFR receptor. So when these receptors are inhibited, there is poor angiogenesis in these areas which are actually pressure points, and they get into friction that there is more of skin peeling and hand-foot syndrome. This is the proposed mechanism, right? And as you know, any angiogenesis inhibitor will so predominantly VEGF inhibitors will have all this hand-foot syndrome and hypertension. So last option is ruled out.
Farewell dinner. कौन सा dinner होता है वो? अरे नहीं, country nurse वाला नहीं.
From the host, you can mute all people who
German
want.
dinner.
Yeah. Anyone wants to answer? Please unmute, ask and mute yourself.
So is it the first option?
Yeah, we'll go one by one. So steroids to be given for hand-foot syndrome and fatigue. Do we do that? What do you do for hand-foot syndrome?
So usually we apply topical something.
So you prevent it through urea-based creams. When it is occurring, you try and reduce the dosage and try giving symptomatic treatment. Clear? So all these urea-based creams are for prevention and also for treatment. As symptoms are mild and they will subside by themselves, observe. do these subside? Does hand-foot syndrome, fatigue, and hypertension of TKIs
No,
are self-limiting? No, exactly.
no.
So they are going to either stay in the same grade or they might have a worsening of the grade of symptom. Yes? Clear? So this is from the CTCA grading system for sunitinib, which says fatigue of grade 1, grade 2. This is how it is graded. So you have fatigue, hand-foot syndrome, hypertension, hypothyroidism, diarrhea. These are the major adverse events which are graded from grade 1, grade 2, grade 3, and grade 4. You need not remember any of the grading systems, but you will have to remember the class side effects, which are like your hand-foot syndrome, hypertension, and fatigue. So indirect inhibition of pro-angiogenic pathways of VEGF and PDGF. So causing prevention of your vascular repair mechanisms, which will cause functional problems in the high pressure areas. Basically, it is going to happen only during the first month of treatment. So that is why we try and do all your preventive measures during the first cycle itself. And this is what is given for multikinase inhibitors. Do not take this as a generalization for your chemotherapy like lipodox and capecitabine also. The mechanism there is different. The worsening is usually there, and it is not only limited to the initial part of the treatment. Am I clear? So all the high risk factors to be avoided. Just a moment. Right. So hypertension is a class effect of your TKI which targets VEGF. Grade 1, grade 2, you have to give a antihypertensive. Grade 3, grade 4, you might have to start your antihypertensives and also stop sunitinib till it comes back to grade 1, grade 2. So most of the times, all grade 2, grade 3 and 4, you will have to stop the treatment, wait for it to recover to grade 1, grade 2. Only in grade 1, grade 2, you can kind of continue. Am I clear? So
Yes.
the only way to actually treat all these hand-foot syndromes and hypertension is one, reducing the dosage or making the schedule different. Instead of giving 4 weeks and then 2 weeks off, there are different schedules trying to decrease the toxicity. So schedule differences and then your dosage differences, adding an antihypertensive. This is your treatment for mild or grade 1, grade 2 side effects of TKIs. Clear?
But sir, for grade 1 and grade 2 HFS, we don't reduce the dose of sunitinib.
But for grade 1, grade 2, you can grade 1, grade 2 of hypertension, you do.
Okay,
And
sir.
among this, all the other options are ruled out. That is why you probably have this is the option, this as the option. If the options which you people have given me are right, then among these, this is the possible answer.
Sir, actually, the patient has taken sunitinib for 2 years. Then
Yeah.
after that, they are saying that patient has mild like HFS, fatigue, and mild hypertension.
Yeah,
So it didn't develop like within 1 month or 2 months.
exactly.
So can we observe?
If all these options are right, now the question is between do we reduce the dose and add a antihypertensive, or do we give treat it as mild and the symptoms will subside, and do we observe? Both the answers are now to be actually taken into account. When you are going to treat the hypertension, you need an antihypertensive, which is not in the answer B. Actually, you need not reduce the dose for hand-foot syndrome at all. If you see the hand-foot syndrome treatment, it is never asking for dosage reduction unless until it is grade 3, grade 4.
Yes, sir.
So if the options given and the question is right, both the answers are actually tricky. If 2 years, if you take into account all the points of your question, then possibly this second option will be the right answer.
Okay, sir.
Clear? Fatigue management is easy doing the schedule changing. And if absolutely necessary, a dose reduction. So these are very general terms. So whether that fatigue was really requiring a dose reduction or not, we don't know. And to add on is, it is not dose responsive. Remember that. So fatigue treatment is most often a schedule change rather than a dose reduction. Only if extremely necessary, then you do a dose reduction. So take home points. 1, how is the mechanism? Second, how do you manage grade 1, grade 2? And what do you do for grade 3 and 4? Only in grade 3, 4, you're going to stop the drug, add antihypertensives and treating all your side effects. And then coming down on the grade, then you restart the treatment. Am I clear? Any doubts? Any doubts? Shall we move on? Chronic change with the SVCO, azygos dilatation, protosystemic shunt, or subclavian pulmonary shunt. What is that? What is the answer? Yes, it is azygos dilatation. So any SVC syndrome can be supraazygos or infraazygos. These are very basic anatomical descriptions. Basically, when there is an obstruction, the whole system of your upper limbs and your head and neck venous drainage is supposed to happen through your inferior vena cava. So to direct your blood to IVC, the only shunt is going to be your azygos. So when it gets kind of the whole flow of it, it is going to get dilated. So most common cause of SV syndrome among all causes. You take cancer, you take non-cancerous condition. What is the most common cause of SVC obstruction? You can unmute and answer. That is why I brought you people inside.
Malignant causes.
Nowadays, catheters. So even if you put all the catheter-related problems inside, still malignant causes. Among the malignancy, lung cancer. So remember 3 things. 1, malignancy versus non-malignancy. It is malignancy. Among malignancy, it is lung cancer. Third thing, you put all non-neoplastic causes in a single group, then catheters are one of the major reasons among them, but not to even a smallest extent of your contribution from your malignancies. Clear? These are possible questions wherever. These are the questions in your NEET SS as well. So it can be either a supraazygos or an infraazygos obstruction. Clear? Thymus-related obstructions are usually supraazygos. Sometimes it might happen that you have a lymph nodal obstruction, infraazygos also. If it is supraazygos, that which is going to be directed to the azygos is through the other channels like this. Right? These are anatomical descriptions. Basic point to remember is the only system which is going to kind of divert the venous drainage is your azygos system. Clear? So all these are symptoms of your superior vena cava cell obstruction syndrome. Hoarseness, visual disturbances, epistaxis, headache, dyspnea. If you see one patient with the SVC obstruction, you will remember all the signs and symptoms. They will have severe facial congestion, upper part of the body, your chest and shoulders will be swollen up. The thoracic veins will be distended. There will be prominent proptosis, laryngeal edema, and so on. Laryngeal edema is the reason for hoarseness of voice. So, see, this is more for a chronic obstruction. Acute obstructions do not have all these shunts or dilatation happening. So remember the second most important. So first is the causes, the types of obstruction superior or inferior, and then how do they manifest? And usually these um, uh, compensatory venous drainages happen only during the chronic obstruction. Yeah. So bypassing the obstruction is mainly required when there is a chronic obstruction. Someone is actually having a scribbling on the iPad. Can you please erase that? Yeah, perfect. Thank you. The old ones also, please try and erase. It is back. None of these anatomical parameters are important for us. We just have to remember what is chronic and how do we treat. At the level of azygos vein, significant compensatory dilatation of the same. Okay. There are types. I don't think those are going to be important for us. Tumor lysis syndrome, which is not useful. Steroids, perfect. Mechanism of allopurinol. Question was on slow grade mild SVCO. What is a slow grade mild? I think we should have waited for questions to be even more clear. Xanthine oxidase inhibitor, RAX, buricases. RAS buricases. Recombinant urate oxidase. Febuxostat.
Xanthine oxidase.
Xanthine oxidase inhibitor.
Right. So what is the peculiarity of a febuxostat?
It can be given in renal dysfunction as well.
These are the take-home points. Very clear. So who is this? Oncodoc. Slowly developing SVCO, which is seen rather than chronic change. So what are they trying to question? Answer is clear, right? Is there a change of, do we mean it differently by this question? Yeah, fine. So what do you do when there is a breakthrough vomiting, which is refractory?
So add benzodiazepines.
Right. When do you use benzodiazepines? Still has vomiting after chemo is breakthrough vomiting. Clear? So what is, when do you use benzodiazepines?
So it is used for anxiolytic as an anxiolytic as well as
So when do you use? What type of vomiting?
Refractory and
anticipatory vomiting.
Anticipatory vomiting. So when do you give this benzodiazepines?
It is given one night before and just before the chemotherapy.
Exactly. That's all. So lorazepam 1 mg 1 day before, right? I'll come to that breakthrough haloperidol all stories. So you have options of giving a D2 blockade with haloperidol, increasing the dose of this 5-HT3, benzodiazepines, add aprepitant from next cycle. So benzodiazepines is out. So this is breakthrough vomiting. This is not anticipatory vomiting. You are clear about that, right? Question is for breakthrough vomiting. Are we having any doubt in that?
No, sir.
Yeah. So you are clear that it is for breakthrough vomiting, right? Right. So now, do we increase the dose of 5-HT3? What are all the 5-HT3s, you know?
Ondansetron, palonosetron.
Question will not mention breakthrough. How do you define breakthrough vomiting?
In spite of giving prophylactic antiemetics, still the patient.
In spite of giving adequate prophylactic antiemetic for that class of drugs. If it is a moderate emetogenic, you should have given a proper moderate emetogenic regimen. If you have actually given a mild hematogenic regimen and then you are saying there is continuous vomiting, it is not breakthrough. Clear? Okay. Some answers, please. So, what is the dosage of ondansetron?
4 mg or 8 mg BD or 4 mg TDS.
At a
8 mg
single
BD.
dose, how much to give? I don't know whether that is there or not. Ondansetron. So total dose can go up to 24 mg. Okay, 8 mg TDS is also okay. So for the breakthrough vomiting, leave around all this main thing, principles alone you'll have to remember. Do not get tensed with this whole slide. I'll tell you what is the relevant point. So give an additional agent from a different drug class. That is the first point. And choice of the agent should be based on your prevention strategies used. So if you have used a 5-HT3 and a steroid, no point in giving another 5-HT3. That is also clear. And once you know there is a breakthrough vomiting, give continuous anti-emesis. Do not wait and give SOS type of treatment. This is also clear. If there is ongoing vomiting, you are going to do IV. All these are very basic stuff. And among the options available, you have steroids, you have olanzapine, metoclopramide, haloperidol. All these are there. But by studies, olanzapine is better than your for breakthrough vomiting than your metoclopramide. This is the only study which we have, which says 70% versus 31%. It's a huge difference. Clear? But did the question give an option of olanzapine?
No, sir.
No, sir.
Right. So you will have to choose from the other ones. Consider changing from NK1 containing agent to a olanzapine containing regimen or vice versa prior to the next cycle of anti-cancer agents. Clear? So adding a NK1 antagonist, adding apripitant from the next cycle is the answer for this question.
So, but then this will not have the effect in the current cycle, na? The patient currently is having breakthrough vomiting.
Correct. So in that sense, I think further D2 blockade with haloperidol, because for ongoing vomitings, you will have to give all these, one of these agents, which is not given in the first book. So again, coming back to the question, if we are right, this is for continuous vomiting, you give a D2 blockade. For prevention of next cycle, you add either olanzapine or apripitant along with your 5-HT3 and steroids. You will not increase your 5-HT3 antagonist dose, which is of not any use. For anticipatory, you use benzodiazepines.
The question was refractory vomiting, actually, sir, not breakthrough.
It's called refractory breakthrough vomiting.
So it was written that after giving usual antiemetics, then what to add? So
why can't we add lorazepam or benzodiazepine?
yes, sir.
Benzodiazepine is only for anticipatory vomiting. It's not for an ongoing vomiting. You understood?
If it's a refractory, we can't give benzodiazepine, sir.
No point.
Okay.
It is only going to prevent the next day's vomiting cycle. It is not going to prevent whatever is happening now. Thank you for actually bringing that point that the patient is actually ongoing vomiting. If these options are right, benzodiazepine is out of the story. Increasing the dose will not actually answer the question. Adding an apripitant from next cycle is for the next cycle. Currently, if you want to do something, you have to do a different mechanism. If there was olanzapine, it is olanzapine. If there is haloperidol, it's haloperidol. If you have, see?
Sir, olanzapine was not there.
So you either have atypical antipsychotics, cannabinoids, or others. Haloperidol is one among the others. Any nausea, vomiting, breakthrough treatment for anti-cancer therapy induced nausea vomiting. So refractory is also a refractory breakthrough vomiting. Clear? You have either acute, delayed, breakthrough, or anticipatory.
Actually, in the options of the breakthrough treatment, we also have benzodiazepine in one of the options. So it includes olanzapine. It also includes benzodiazepine. The last option is benzodiazepine, like lorazepam, sir. So I think haloperidol would be a better option. Is that what you're saying, sir?
See, this is what is the summary from your. Then I'll have to get deeper into this to find whether real. In practice, what we are doing is doing only benzodiazepines for anticipatory vomiting. And for an ongoing vomiting, I don't think benzodiazepine is actually going to add on anything.
But your lorazepam is written.
So in practice also, sir, if patient is having chemotherapy-induced vomiting, after giving all our usual antiemetics, generally we add, sir, either lorazepam or midazolam, sir.
But given a choice of D2 blockade versus benzodiazepine, I think D2 blockade will slightly win over
Actually, if you go by this line, multiple concurrent agents, perhaps in alternating schedules or by alternating routes, may be necessary. Dopamine antagonist, example, which has haloperidol, olanzapine, steroids, and agents such as lorazepam may be recommended. So what are they actually trying to ask? Even I'm confused.
So olanzapine also belongs to the class of benzodiazepine. So can we say that it also belongs to the benzodiazepine class?
Which one?
Olanzapine, it belongs to benzodiazepine.
Yes,
No. Olanzapine is still an atypical antipsychotic, so that is kept separately.
And olanzapine was
Yes,
not in
the
the
answer would have been actually if they have given olanzapine, it has the trials to actually show you in all these settings. Whereas individual agents of your haloperidol and raising your 5-HT3 antagonist dosage or benzodiazepine do not have so much data behind that. So I'll get back with an answer for this also. We will have, I think we'll have to have multiple sessions to find out actually what is the answer. Switching to another one with a different pharmacokinetic profile, but no data to back up that. I think all of you are sure these are the options, right?
Yes, sir.
Yes, sir. These were the options.
All your AI questions, even I have to read back. I'll tell you all your AI questions in the last part of the discussion. I mean, on day 4 or so. So, all are given alone except what is the answer here?
Cortisone.
Why? Why so?
So there was some trial.
No, why don't you
So
give
it works on
second?
dimerization.
So what? Heterodimerization, homodimerization, all these words are good to hear. Why dual blockade is needed? Dual blockade, whenever you need a single blockade, you are happy giving trans 2. Why not happy giving only PER2?
There was some trial.
Increase the toxicity. HER2, HER3. What is the difference of HER2, HER3? See, among this, which one doesn't have a ligand?
HER2.
HER2. All others have ligand. So what is the site where pertuzumab acts?
D2 domain.
Domain 2 of HER2.
So what is that domain used for? So it basically does.
HER2-HER3 dimerization.
So it is here wherein it binds to an area where there is ligand dependent dimerization. Got it? So if you are giving only PER2, It is going to prevent only a ligand dependent dimerization. On the other hand, ligand independent dimerization might still go on. Am I clear?
Yes, sir.
Clear?
Yes, sir.
Yeah. And try and remember all 4 mechanisms of trastuzumab. What is this P95? This might be another question at some point of time. This is a breakage product from the receptor, and this is one of the resistant mechanisms for trastuzumab. When the domain just cleaves off, and this alone stays back on the left side of this slide. Clear? Any further explanations? So points to get back to you are your CIN. Raising your IH3 antagonist dosage or benzoyl do not have so much data behind that. Sorry? So I'll get back with an answer of what is also. I think we'll have to have multiple sessions to find out actually what is the answer. No?
So we missed question 6.
No, that was, your AI question is missed. I'll get back to your AI questions, clubbing up together. I'm just going in the. Switching to another one with a different pharmacokinetic. I'm fine, but no. Some weird echo, yes. I think I'll have to mute someone. Right. I will have to leave shortly, so I'll finish off few more questions. I'll get back to you on this CINV part. Clear? Am I audible? Yes, I think so. Sodium is low. Answer is clear, SIADH. Yes? So, how do you actually treat SIADH in these patients? What is the first thing?
Fluid restriction.
No, how do you actually approach? First is to find out whether it's an acute or chronic hyponatremia. Okay, that is the first step to remember, to understand how do you go about any patient with hyponatremia, because treating an acute is always with sodium corrections of 4 to 6 millimoles per liter or up to 8 over 24 hours, wherein you can give hypertonic salines if it is symptomatic. In chronic alone, you can use your tolvaptan and all vaptans. Am I clear? That is the point of trying to differentiate between acute and chronic. Fluid restriction, yes. So SIADH is because of euvolemic hyponatremia. There are hyper and hypovolemic. You can have a patient with chemo vomiting and having a hypovolemic component also. So there is no one mechanism which is causing hyponatremia in any patient always. Clear? So all these can be the causes. It may be a prognostic factor, mainly in small cell lung cancer. Okay. It can be because of ADH secretion by the cancer. Drugs can also cause all this, like your vincristine, cyclophosphamide, and so on. And remember, any individual with the high risk, like alcohol intake or less than 105, or liver disease, hypokalemia, malnutrition, and so on, wherein rapid corrections might actually precipitate an osmotic demyelination syndrome. Your target is only 6 milliequivalents per day. Rise. Clear? So these are the take-home points. Few more minutes. So which of the following is not a treatment for metastatic pancreatic cancer?
Capello.
Caperlo. So FOLFIRINOX is yes, Gem-Nab-Paclitaxel yes. Gemcitabine erlotinib, where is it used and what is the advantage? How much is the advantage? And why are they using erlotinib in pancreatic cancer? So it is mainly in locally advanced that it was tried, and addition was only giving a 10-day median increase of survival as opposed to the single agent gemcitabine. So it did not actually become so much popular because of the very small benefit, but that was statistically significant. Henceforth, got the approval. Clear? So this is like 5.9 months to 6.2, I think. 6.2. Basically, 10 days difference was the clinical benefit. Clear? Any further discussions? Two, three questions, and then I'll get back to you on next class. Main advantage of implantable port, preventing repeated venous access. I don't think any further discussions will be needed in this. So basically, it is for safe access when there are poor veins or you want multiple transfusions, mainly for infusional chemotherapies. Okay. Yes, I'll get back to you. So what is a receptor for respiratory depression? Mu receptor. See, these are bizarre questions. Even I have to read before getting back to you. Only the respiratory and cardiac depression is only for mu. If you see for delta and kappa, those happen without any respiratory compromise. So when there is a respiratory compromise, what is the drug given?
Naltrexone.
Naloxone. The problem of naloxone is it will reverse your analgesic effect also. That is the problem. Okay. Full opioid agonists are morphine and fentanyl. Partial or very weak agonists are your buprenorphine. I will have this is again a vague question. What is the answer here? Most common cardiac side effects of cisplatin?
The QT prolongation.
Ischemic heart disease, QT prolongation, systemic hypertension. The problem is all your these are mainly your case report based explanations which I got. All are possible, but they really pin down to some kind of arrhythmias. But pericarditis is possible, hypertension is possible. I'll have to read back and I'll try and connect to the national board who is setting the paper to understand where they get the reference from. MI is mentioned, but which is most common is exactly. So all these are mentioned, but which are they trying to mean as most common? We will have to think again. Hypertension is most common. Do you have a reference for that? Each are based on case reports. The problem is none of them give a proper reference. This et al, that et al. Two more questions for now. Gemcitabine, what is the side effect?
Myelosuppression.
Myelosuppression. What among that? Neutropenia or thrombocytopenia?
Thrombocytopenia.
It is not thrombocytopenia. Neutropenia is more common. Okay. Problem is you see more thrombocytopenia with gemcitabine than others. How can they ask rare side effects? Yes. How they asked about AI. So asking about a rare side effect is acceptable. So among the myelosuppressive components, neutropenia is more commonly observed than thrombocytopenia. just few take-home points from each one of this. Here. So what is this? IgA with
Smoldering myeloma.
smoldering myeloma. A is the
Smoldering
future. AI getting into NEET MCQs is little. Actually, all these AI-based questions will have vague answers because we do not have a proper explanation and reference for that. Okay. I think with this question, we try and wind up. So what is this IgA kappa? How do you differentiate? What are the two types of MGUS? This is smoldering, right? But what are the two types of MGUS?
So non-IgM and IgM.
Exactly. Non-IgM and IgM related. And bone marrow is 40% clonal plasma cells. Still, do you want to call it as smoldering than myeloma?
Myeloma is more than 60%.
More than 60.
Yeah. So what is that called?
So multiple myeloma.
Slim cap criteria.
Myeloma defining event.
Okay, sir.
Okay. So slim crab is among those. There are different. See, M component is never a myeloma defining event. Remember that. What is the expected cutoff for this paper? Don't fear. None of us are clear. Even the examiners will not be clear as to what is the real cutoff wherein it is going to differentiate between people who are going to get in or not. So it is again a suspense still you are getting. How did you find the paper overall? Sir, I think at the end of your exam, what were going through your mind was the same feeling when I read all these questions. Because we tried concentrating on recent advances, so much map, this, that, and they actually pulled us down to basics, actually hit very hardly in the basics. But these are really unexpected questions. We might not expect all these very basic questions in multiple different ways.
So there are many questions which are directly from the question bank of some other coaching center. Like,
That
this
is
not
also put
fair.
into the group. We are discussing on that. We don't know how. See, I expect all these myelomas, even SVC syndrome anatomy is acceptable. Your CINV, smaller confusions are acceptable. But erectile dysfunction questionnaire based question or your receptor of an opioid based question and getting replicated is extremely fishy. The easiest explanation which would have been given is many of them are taking questions from the AI directly. So whether it is an AI generated question which is being shared between both of them, or is there something else going on, we don't know. This would be another point to people join there than get into DocTutorials. Yes. TK adverse effect. True. TK adverse effects. Even in our DM exit exam, we did not have this stuff from TK questions.
So there are so many questions where questions were not clear. Like they are giving neutropenia, but they are not mentioning whether it's grade 1 or grade 2 or grade 3 or grade 4.
Even your first question did not have a grade. CTCE grading without that.
And they're asking for the treatment, sir. How will I know what is the grade and how will I go for the treatment?
Yeah, true. We'll get back to your cancer cachexia in detail, a small discussion in the next session. And from that, we'll take on through the other known questions. So initial 2 sessions, only the known questions and taking salient points from that. Last 3rd and 4th session, we'll try and do the controversial questions and the AI-based questions. Am I clear? I think I'll have to move for now. I'll get back to you very shortly by Sunday or so. Thank you.
Thank you, sir.
Thank you,
And
sir.
guys, again, it is tough getting back to you on the WhatsApp groups. Please call anytime. Sometimes we might be busy that we will not be able to receive your calls, but just collect all your doubts, call up at some point, or please put a text. There are many of you trying to ask time so that they can connect at that point of time and clear the doubts. Same way we can do for all of you.